Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios. According to the American Cancer Society, pancreatic cancer accounts for only 3% of cancers in the U.S. What's important to point out, though, is how low the survival rate is for this disease. The overall 5-year survival rate is about 8%, depending on the type and stage of the cancer. But there are different treatments available today, as well as clinical trials that have promising results for the future of pancreatic cancer. Joining us today to discuss the treatment of pancreatic cancer, we have 3 fantastic doctors joining us. Let's start with Dr. Horacio Asbun. He's the Chief of Hepatobiliary and Pancreatic Surgery at Miami Cancer Institute. Also joining us, Dr. Raj Narayanan, Chief of Interventional Oncology at Miami Cancer Institute. And finally, Dr. Ripal Gandhi, interventional radiologist and interventional oncologist, also with Miami Cancer Institute and Miami Cardiac and Vascular Institute. Welcome, doctors.
Morning.
Morning.
Thank you.
Thank you so much for being here. First, I want to start with just educating the public on, your roles at Miami Cancer Institute and what you do when it comes to pancreatic cancer and pancreatic surgery. So, Dr. Asbun, let's start with you.
Thank you, Olga. Good morning.
Good morning.
Thank you for having us here.
No, thank you for being here. It's a pleasure.
I'm the Chief of Hepatobiliary and Pancreas Surgery at Miami Cancer Institute and Baptist Health South.
All right, and Dr.
My name is Raj Narayanan. I'm the Chief of Interventional Oncology at Miami Cancer Institute and an interventional radiologist at the Miami Cardiac and Vascular Institute.
And Dr. Gandhi, your role as well?
Yeah, I'm an interventional radiologist and an interventional oncologist at both the Miami Cancer Institute as well as Miami Cardiac and Vascular Institute.
All right, and as I mentioned earlier, doctors, pancreatic cancer, it accounts for only 3% of all cancers. The number is very small, so it isn't very common, is it, Dr. Asbun?
No, it's not that common, but the importance comes because it's one of the most malignant cancers, as you have said.
Exactly.
And traditionally, we have not had enough funds to do research just because it's not as common as other type of cancers. Now we're starting to have a significant awareness of the disease, and that has helped us to make a lot of progress.
And we've had significant awareness because of certain celebrities in the news. Just recently, Aretha Franklin, the soul singer, fantastic, may she rest in peace. She passed away from pancreatic cancer, and back in 2011, of course, we can't forget, CEO and co-founder of Apple, Steve Jobs, also passed away from this terrible disease. So when something so unfortunate happens to, big names like these, the awareness does grow. Is that correct, Dr. Gandhi?
Absolutely. I think having celebrities diagnosed with this cancer definitely raises the awareness of the disease. And as Dr. Asbun stated, despite, some of the advances in the disease over, the last, many years, there really hasn't been a significant improvement in survival until more recently, with improvements in surgery and some of the therapies we're going to be talking about today.
And we're going to talk about that exactly all hour long. Dr. Narayanan, I also wanted to hone in on the fact that when we hear of Aretha Franklin, Steve Jobs, and others that have passed because of this disease, it really does help educate people on the subject, doesn't it? People start to ask questions. They start to just be a little bit more mindful of, okay, what is this and what happened?
Absolutely. I think having celebrities or prominent personalities affected by a certain condition does raise the awareness. It's unfortunate for them, but it definitely helps the common cause.
And that's what we want to do today. We want to educate our viewers on pancreatic cancer and the new treatments today, and hopefully better news in the future in terms of survival rates. Dr. Asbun, I wanted to go through risk factors to start off the conversation on this. We have a graphic to educate our viewers. Family history seems to be number one.
Yeah, yes and no.
Okay.
I mean, if you have several members of your family, especially first relatives, yes, it is important. However, if you have had a single relative, or you have a couple of relatives that are far away from you, then it is not that important as so.
So it's more proximity, like a mom or dad?
That is correct.
Or a grandparent?
And the number of family members that they have had it.
How about diet? How does that play into this, and obesity?
Diet plays a significant role, as in any other cancer, in terms of obesity. Alcohol is important because there's a clear association between alcoholic pancreatitis and chronic pancreatitis and pancreatic cancer.
All right.
What is important too is smoking.
Yes, smoking seems to always be on these lists of risk factors.
Unfortunately, yes.
Yes, and
or fortunately, because it's something that theoretically we can act upon.
Absolutely, it's something that we can do, and we should never start. Let's just put it that way, right?
That's correct. Yes.
Race and gender, Dr. Asbun?
There are some studies, but would be difficult for me to make a clear statement about it.
Okay.
It can affect at different ages. There is a certain decades of life that is more common, but more and more we're seeing pancreatic cancer at both extremes, younger as well as older.
All right, and then the last one, pancreatitis. What is that?
Pancreatitis is inflammation of the pancreas, and as I had mentioned, one of the types of inflammation of the pancreas is caused by chronic alcohol use and or abrupt excessive alcohol. And when that happens in repeated manner, the pancreas gets inflamed, gets scarred. The scarring produces fibrosis, and in the long term, that can lead to cancer.
Dr. Narayanan, let me bring you to the conversation. I've noticed that pancreatic cancer is not often detected at early stages. Why is that? It seems like once you get the diagnosis, we're already talking stage 4.
Yeah, that is one of the downsides of pancreatic cancer, one of the main ones, because most of the patients have vague symptoms and typically don't seek medical help for that, and you put it away, and many of them are actually diagnosed when they go to the emergency room or to their physician for another problem, and they get scanned for that. So that's when usually they see that there's a problem with the pancreas, or they wait for some time and then they start seeing that they're jaundiced, and there is go to the physician for that, and that's when the investigations are started. So typically it's diagnosed late. Usually by the time they're diagnosed, nearly 50% of these patients would have the disease outside the pancreas.
Exactly.
And it has metastasized.
It has metastasized through the body. We're going to talk more about that as well. I want to put up a 3D image, if we can, to educate our viewers on stage 4 pancreatic cancer. So if Dr. Asbun, you could go to our 3D image wall, tell us what we're looking at, and explain what we see here.
Well, what we're seeing here is you see the image of a person standing up. Obviously, the head is in the top. These are the arms. You have the heart. The heart is in the chest, and then there's a muscle here that's not depicted on the drawing that separates the chest from the abdomen. In the abdomen, we have the majority of the organs like the liver, the pancreas, and the intestines that are not in the drawing. Then on this case, the drawing is depicting a tumor that's located in the pancreas. The pancreas is an organ that comes across the whole abdomen from left to right. This is the left side of the patient. This is the right side. And we have the part of the pancreas that's called the head. This is the body and the tail. This would be a tumor on the body of the pancreas. And the way how this is shown shows that there are metastases. Metastases are branches of the initial tumor in the liver. But of course, this is a stage 4 pancreatic cancer, which is not when you want to diagnose it. And again, more and more of the research is trying to show us that we can detect this earlier.
And obviously, Doctor, and it's so wonderful that we can see the close proximity of the pancreas with the liver. That's what makes it so dangerous as well, because of the fact that it migrates up, and the liver, of course, you know, we can't replace it. It's very difficult, obviously, we need it. I mean, I know there are liver transplants, but it's a vital organ, if you will.
It is, but it's not so much the proximity, because the metastases go really by 2 ways, either the blood flow or the lymph nodes. And what is interesting is that we have learned more and more that pancreatic cancer, you can detect cells as well as DNA in the blood very, very early in it. Then we now know that pancreatic cancer spreads not only because of proximity, but also because of a different mechanism early on in the part of the disease.
All right, thank you for that, Doctor. We want to also now educate our viewers on the symptoms you may have. Dr. Narayanan mentioned some of those, but Dr. Gandhi, let's talk about these. And yellowing of eyes or skin, why does that occur?
Yeah, that's what we call jaundice, and that's really due to obstruction of the bile ducts by pancreatic cancer. Typically, for pancreatic cancers that are located in the head of the pancreas, as Dr. Asbun described. Other common symptoms include weight loss, abdominal pain. You could have itchy skin, what the medical term is pruritus, dark urine, or pale or greasy, smell-filling stools are common as well. And patients commonly might experience some nonspecific symptoms as well, some fatigue, tiredness, and sometimes a lot of these specifics are nonspecific, and for these reasons, unfortunately, a lot of these patients are diagnosed late in their stage.
All right, and speaking of stages, Dr. Gandhi, we talk a lot about stages in terms of cancer, stage 1, 2, 3, and 4 obviously being the worst. This is used for pancreatic cancer too, but you also categorize when it comes to pancreatic cancer on how it's advanced. So Dr. Asbun, can you touch upon that a moment of what that means, how much it's advanced? I believe it's called resectable borderline.
That's correct. The term resectable means that you can actually do surgery and take it out.
Okay.
Because today we have multiple different modalities that we'll be talking about, but there's no doubt that the only chance for cure is when you can actually take the tumor out with surgery. Then resectable means so you can take the tumor out. Now we have different stages because you can have a small early cancer that you take the patient directly to the operating room and it becomes resectable, or you can find a patient with what's called borderline resectable. Borderline means that it's locally partially advanced, not like we showed before with metastasis branches far away, but it's locally advanced. What happens is the pancreas is in the back of the abdomen and it wraps around some very important vessels. Then borderline resectable, the term was developed stating that it has a relationship with those vessels, either wrapping it around completely or not, and I'm not going to bore you with the details of the definition. But once it's borderline resectable, then it is a ring bell for us to say, okay, now this patient probably should go first to other therapies like neoadjuvant therapy. And then it goes first to the oncologist. We're very fortunate at our institution at MCI to have a great group of oncologists that allow us to treat this disease and make it from borderline resectable to resectable.
All right, and I also understand that there's always what you all call a multidisciplinary care at Miami Cancer Institute. Dr. Narayanan, can you explain what that is, please?
I think a well-formed multidisciplinary group is crucial for any cancer institute and also for delivering high-quality care to cancer patients. And we're fortunate at the Miami Cancer Institute to just have the same. We have world-class physicians from multiple specialties, from hepatobiliary surgery, medical oncology, radiation, and interventional oncology, which is our service, all working together. We meet every week regularly where complex cases are brought to the tumor board and discussed. It allows us for each one of us to give in, to share our opinions about what we could bring to the table, and thereby delivering the best possible treatment for this particular patient. So,
and I really appreciate that because it's an individual approach. You examine each patient on an individual basis, correct, Dr. Gandhi?
Yeah, I think that's really the key. We personalize care.
Right.
So you have all the specialists. We all meet together to discuss each individual patient. We review their imaging, their pathology, any treatment options that the patient had before, and really determine what is the best option for this individual patient. And one of the other things I want to add is that Miami Cancer Institute is part of the Memorial Sloan Kettering Alliance. And what that means is there are 3 hospitals in the United States which are part of this MSK Alliance. And this allows us access to broadened clinical trials and advanced studies, which is really key when we want to advance the treatment of cancer.
Dr. Asbun, I'm going to take a quick break, but would you like to add something real quick?
Yeah, I mean, I just want to tell you all that this looks like advertising. We're advertising, but it is not.
No, I actually think it's fantastic.
Right. In fact, several of us have come to this institution recently from very good, well-named institutions because we like the vision and we like the fact that we all work under the same roof and we can even see patients together. Then the patient has the opportunity to have multiple opinions. It's like, one of the things that are important is to see a second opinion every time. In this case, you have a second, third, fourth, or even a 20th opinion because on our disease boards, we have multiple physicians that are top leaders in their field and can give the patient a second, third, and 10th opinion.
You called it advertising. I called it empathy. I, at that moment, was thinking of if I had a family member who was diagnosed, I would want to be in your hands because it really seems like you take that personal approach. And at that moment, when you get the diagnosis, this is what you want.
That's correct.
Absolutely.
So empathy, I think, is the best word to say for all 3 of you. Thank you, Dr. Asbun, and all of you. We're going to take a quick break. When we come back, we're going to be talking about some of the different procedures that may be used to treat pancreatic cancer, including one called the Whipple procedure. So stay tuned to hear what that is and who's a good candidate for it. You're watching the Health Channel, all health all the time on South Florida PBS. If you have a question for our experts today, please call us using the toll-free number. It's 855-796-4475. You can also visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel. You can also watch videos from previous episodes. We'll be right back.
Us. It's what this country is made of. But right now, our bond is framed. How do we get back to us? The Y fills the gaps and bridges our divides. Support your local Y today. Because where there's a Y, there's an us.
Welcome back to the Health Channel, all health all the time. I'm Olga Villaverde, and with us right now is Dr. Horacio Asbun, Chief of Hepatobiliary and Pancreatic Surgery at Miami Cancer Institute. If you have a question for Dr. Asbun, please call us using the toll-free number, 855-796-4475. We would love to hear from you. Dr. Asbun, we talked about briefly or I teased, I should say, the Whipple procedure. I've heard about it. First of all, what is it, and has it been around for a while?
When you have pancreatic cancer, depending the location of the tumor, you're going to do different procedures. The most common location, or at least the better known location, is the head of the pancreas. And when the tumor is in the head of the pancreas, you need to do what's called the Whipple procedure. Now, the Whipple procedure has a really bad reputation because years past, the majority of the patients had a lot of complications and the mortality was quite high. And on that, we did have a significant improvement over the last decades. We do now the procedure very safely. The mortality has dropped to less than 4%, and that's for all comers. And the patients go home now, if you do the new techniques, in an average of 5 to 7 days. The complications rate are still significant. However, it is a group of complications that are much milder than what they were in the past. And the majority of the patients go back to a normal quality of life.
All right, we have a short video where we see parts of the body that are removed during the Whipple procedure and why they're removed. So let's take a look. This is part one.
This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one. This is part one.
As we discussed, the Whipple procedure or pancreaticoduodenectomy, it's a very complex procedure. And that is because we need to take the head of the pancreas out. And the head of the pancreas has very intrinsic relation with the intestine, or the first part that we call duodenum, as well as with the bile duct. The bile duct is really a pipe system that brings the bile that's produced on the liver into the intestine. Now, commonly, a tumor located on the head of the pancreas will obstruct this pipe system or bile duct. And when an obstruction of the bile duct occurs, the bile gets backed up into the liver and reabsorbed in the blood, and therefore you develop jaundice, or what is the yellow color of the skin. And at the same time, the stool color can become clay color because now the bile, that's the one that's responsible for the color on the stool, does not get into the intestine, and therefore the stool again turns white. Now, besides taking the head of the pancreas and the intestine and this portion of the bile duct, we need to take the gallbladder out. The reason for taking the gallbladder out is because the duodenum produces some hormones that help the gallbladder to function. Once we take the duodenum out, those hormones are not present any longer, and therefore the gallbladder doesn't function normally. At the same time, taking all of this out may impair the blood supply of the gallbladder, and therefore the gallbladder again has the risk of not receiving adequate blood supply and be ill. The gallbladder is taken out at the same time of the surgery and really doesn't have any more consequences on the patient than all the rest that we have taken out.
Okay, so that's part one of the surgery, and I wrote down, doctor, gallbladder and bile duct are completely removed, so obviously we can live without those organs because we can't live without the liver.
That is correct. And you don't take all the bile duct because if you want to be a little bit picky anatomically, the bile duct, it goes inside the liver too. Then we take the portion of the bile duct that goes inside the pancreas and the portion of the bile duct that it is a little bit above the pancreas. The goal of the resective part, remember what we talk about resection means taking things out.
Taking things out.
Then the goal of that part of the procedure is to take all the tumor with a margin of normal tissue. Margin means a portion of the tissues that do not have cancer. Because we really, on this particular cancer, we really need to take the whole cancer out, at least everything that we can see.
Real quick, because I'm going to show our viewers part two. If the cancer is localized to the pancreas, why are you removing those organs? Is it because fear of metastasize, or why is that?
No, that's a very good question, Olga. It's because those organs and structures are so intimately related that the blood supply that gets to them, it is joint, meaning that if I take a portion, I may take part of the blood supply of the rest. And also, if I take only a part where the tumor is, I may injure or alter enough the function, the structure of the other portions that would damage. Then you need to take everything in block.
Makes perfect sense. All right, so now let's look at part two of the surgery.
The reconstruction is done by putting all of this back together. If we divided the pancreas here and we call this A, and we divided the bile duct and we call B, and we divided the intestine and we call C, if we take all of this out, we're going to end with this situation. The intestine is called C, the pancreas is called A, and the bile duct is B. We took this whole center part. We also divided the stomach past the area of the valve of the stomach at the first portion of the duodenum, and here we call D. This is usually helpful to be able to preserve the whole stomach. In some cases, we cannot do that because of the location of the tumor, and we need to take a part of the stomach along with the rest of the specimen. But in the majority of the patients, we're able to preserve the whole stomach. How do we reconstruct that? The intestine is the part that's movable. Therefore, we flip the intestine to approximate it to the pancreas and the bile duct. In this other drawing, we have flipped the intestine. The end that we had called C now is located here. We connect it to the pancreas, and therefore the pancreatic juices are emptied back into the intestine again. The bile duct is reconnected to the intestine a little further down the stream, and again, now bile is able to empty back into the intestine. Further down the stream, we reconnect now the stomach to the intestine. And that is how food gets back into the alimentary system. Then the end result is, one more time, the food goes into the stomach, back into the intestine, pancreatic juice and bile get into the intestine here, and all get together, and you go back to have a normal absorption.
I have so many questions after watching that. It's just fascinating what you do. Major procedure, no doubt about it.
There's no question. It's a major procedure.
Major procedure. How long does it take? What's the recovery like for the patient, doctor?
All depends how complex the procedure is for that patient. It can take anywhere between 3 and 7 hours. And sometimes we need to take portions of the vessels that are neighboring, and that makes it even longer.
Okay, how long does the patient stay in the hospital? A few days?
Yeah, today we have enhanced recovery, meaning a process through which the patients have a better experience during the recovery, and they stay in the hospital between 5 and 7 days.
Can this affect how you eat and drink in the future, doctor?
It does, particularly initially, but as the drawing depicted, if you are able to preserve the stomach, the majority of the patients go back to normal eating after a couple of months.
All right, now just like with any surgery, even though this is a major surgery, there are risk factors. We want to show you some of those. And Dr. Asbun, let's walk through these quickly if we may. Bleeding, infection.
Yeah, delay in emptying of the stomach, that's because of the stomach is divided, and you can have leakage from pancreas or bile duct connections, and that's the one that's most feared, and that's the one that over the last several decades we have done major strides because working with our interventional radiologist and what we call a rescue team. Here we circle back to the multi-specialty team and approach. The surgeon is no longer the only one that treats these patients, and if I have a very good rescue team, the patients do much better.
All right, and I understand that this procedure can be done laparoscopically. Is that correct?
That is correct. Laparoscopically means that we do the surgery through small incisions. In these small incisions, we put a cannula. We insufflate the abdomen to create space.
Right.
And the telescope that's connected to a camera reflects the inside image into the screen, and then we do operation watching the screen. It's basically playing fancy Nintendo and having fun on it.
Nice humor right there. Is everybody a candidate for something like that, or?
No, I think that it's very dependent on the experience of the surgeon. These are not techniques that are yet practiced all over the world, but they're very selected centers with experienced surgeons, and the selection of the patient depends on where the location of the tumor is, and more than anything, it's a balance between what the patient has and the experience of the surgeon.
Before we take a break, I was going to ask you, what do you hope people take away from seeing this procedure and what this does for them?
I think it's important to know that the procedure is safe. Even among the medical community, many people, when they hear the word Whipple, they tell the patient, no, that's, you're going to do very bad. Today is a very safe procedure, still very complex, but it is a very safe procedure and gives the patient that chance for cure that is so needed.
Thank you, doctor, very much. Okay, so coming up next, we're going to be talking about another treatment for pancreatic cancer, something called irreversible electroporation that uses high-energy pulses of electricity to destroy cancer cells. So stay tuned for that. You're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for our experts, please call us using the toll-free number 855-796-4475. You can also visit our website, allhealthtv.com. We'll be right back.
Wonder if you should get tested for colorectal cancer?
Is it really that common?
It is. It's the second leading cancer killer in the U.S.
I don't have symptoms.
It doesn't always cause symptoms, especially early on. And screening helps prevent the disease.
Oh? How?
By finding precancerous polyps so they can be removed.
But that test.
There's more than one screening test. If you're 50 or older, talk to your doctor about which one is right for you. Colorectal cancer screening really does save lives.
Infectious diseases spread by pests, illnesses like malaria, Zika, and Chagas disease are causing a worldwide health crisis. Here at home, we don't face the same level of threat, but we shouldn't let our guard down. Mosquito-borne diseases like West Nile virus and Zika are impacting communities across the U.S., and Lyme disease spread by ticks is on the rise. Whether around the world or just around the block, get the facts you need to protect your family at pestworld.org.
You can try to ignore it, but the problem is everywhere. Every instinct says don't look, but sooner or later we must, and our reaction is only natural. Mice contaminate food and transmit disease. Termites cost billions of dollars in property damage each year. And cockroaches can trigger asthma attacks and spread salmonella. Trust your instincts. Learn more about how to protect your family at pestworld.org.
I lost weight without trying.
Bleeding. I gained weight, and I didn't know why.
Pain.
Really tired and weak.
Pencil-like stools.
A sudden change in bowel habits.
My dad was diagnosed with colon cancer. There's a personal history of polyps.
Family members had polyps.
My husband wasn't 50, but something wasn't right with his body.
I have Lynch syndrome.
I turned 50.
If the doctor has said it's time. My family members are turning 45.
I don't have any signs or symptoms, but I am turning 50 soon.
So when it comes to colorectal cancer screening, don't assume that you don't need to be screened.
There are many affordable take-home options. To learn more, go to fightcrc.org.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Raj Narayanan, Chief of Interventional Oncology at Miami Cancer Institute. If you have a question for the doctor, please call us using the toll-free number right there, 855-796-4475. All right, Dr. Narayanan, we were talking, of course, about the Whipple procedure. Yeah. Now, there is a newer treatment, and it's called, and if I say it incorrectly, please correct me, but sure. Irreversible electroporation.
Perfect.
Fantastic. IRE for short. So let's talk a little bit about this treatment and how does it differ from the Whipple procedure?
Sure. So the Whipple procedure is a surgical procedure. Irreversible electroporation is a procedure that is considered an ablative modality. This technology was introduced back in 2009.
Oh, so it's relatively new.
It's relatively new, and it is FDA approved for use in surgical ablation of soft tissues. So when we use it in the pancreas, it's considered off-label. Initially, the technology was developed in UC Berkeley. It uses high voltage, low energy DC current, and you place needles to bracket a particular area in the body. Mm-hmm. And once you connect the needles in the right place and you connect it to the generator, it delivers up to 3,000 volts of high voltage, low energy DC current. And what that does is it creates multiple pores in the cell membrane. Anything that's in between these needles gets electroporated. In other words, there are multiple holes in the cell membrane, and that leads to disruption of things going in and out of the cell, and that kills all the cell organelles. And that's typically how the technology works and kills the cells.
All right, let's paint a picture for our viewers. We have a short video from Baptist Health that shows how this IRE procedure works in more detail. Take a look.
The NanoKnife procedure is an ablation technology that uses the principle of irreversible electroporation. In short, it is harnessing the power of electricity to kill tumors. The areas where this technology has been used mostly, both in the United States and around the world, is in liver, both primary and secondary, and it has other niche applications.
So this is a patient who has colorectal cancer, metastatic disease to the liver. The patient had removal of the right side of the liver. There's still one residual tumor left in the left side of the liver. This tumor happens to be adjacent to a vein, a big vein. So today what we're doing is we're performing NanoKnife of this residual tumor with the hope that we can cure this patient of their disease.
When we perform these procedures with imaging guidance, predominantly use CAT scan guidance. You make about 2 to 3 millimeter incisions on the patient's skin, and you place needles very precisely using imaging guidance. And once the needles are all in place, you do what we call a 3D reconstruction. We see the whole image in 3D. And typically you need at least 2 needles to perform a treatment. So you need a positive and a negative. And you need 70 pulses to be delivered between the 2 needles to complete a treatment. You do a final scan, make sure everything is okay. You'll be able to see the difference almost immediately after the treatment. Most of the times they are in-house just for one night, just for observation, and they typically go home the very next morning.
I think it's definitely an impressive technology. It's not used for everybody, but for the right patient, it can be extremely helpful.
One main area of my personal interest, where I've been working on for the last 9 years, is the role of nanoknife in pancreas.
Patients who have locally advanced pancreatic cancer, a lot of these patients have very limited other options. So this is where nanoknife can be very helpful. Nanoknife really gives us now the full complement of interventional oncology therapeutic procedures. So this is one of few centers in the entire country where we pretty much have every single modality available to treat patients with cancer from an interventional oncology perspective.
So I'm going to ask you the same question I asked Dr. Asbun, which was with the Whipple procedure, and he told me it's done when the cancer is localized in the pancreas. Is the same for this one as well?
Yes, the ideal patient for a percutaneous treatment with the nanoknife would be somebody with localized cancer with a disease that's confined only within the pancreas, but also based on our experience, we noted that patients with a tumor size less than 3 centimeters do better than those who are bigger.
And can you explain to me, or to our viewers, I should say, the high voltage electricity, how does that treat the cancer? Does it kill it?
So it is a localized treatment when you're exposing the cells, tumor cells, to such a high voltage of electricity. The way the cell dies is because the energy creates pores or holes in the cell membrane.
Okay.
So in the tumor cell membrane, and that disrupts what we call the homeostasis mechanism, which is stuff going in and out of the cell is disrupted, and anything inside the cell dies. And this is how the cell death occurs.
Is this minimally invasive?
It is considered minimally invasive because we're using imaging guidance. The same procedure initially, when they started treating pancreatic cancer with this technology, was done in the open setting, in the operating room. So back in 2010, I started this technique to treat this without surgery by just using imaging guidance. So it is considered minimally invasive.
So there are a lot of benefits as opposed to, let's say, that open surgery.
The key benefit would be that the recovery time is much faster,
exactly.
And the hospital stay is a lot shorter. They typically stay in the hospital for a day or day and a half.
All right. Well, just like any surgery, I always have to say there are potential side effects. So let's take a look at some of these and let's chime in on them. Some pain, doctor?
Yes. Yes.
Minimal pain, or
usually pain is a very subjective symptom.
Exactly.
So most of the times the pain is something that can be tolerated by patients on a scale of 0 to 10. We would say about 5. Inflammation is something that is expected. Pancreatitis, around inflammation around the pancreas, is something that we talk to patients about. Problems with eating and drinking, not usually very common. And formation of blood clots anytime somebody is hospitalized or prolonged in the bed rest, that is usually a risk. But with this particular procedure, one of the key things we worry mostly is about the abdominal pain and discomfort.
I wanted to touch upon something that you mentioned a few minutes ago about this procedure being used for pancreatic cancer off-label. Can you explain that for us?
Yes. Many of the technologies that we use is considered off-label. The reason we say it's off-label is that the FDA, US FDA has approved it for given it as general indication called the 510K. In other words, it's approved for surgical ablation in soft tissue. And when you use it in a specific organ, that's considered off-label. But this is something we always discuss with our patients when we see them in consultation. And again, many of these technologies have been around for many years, and there's a lot of data that has been published. And some of them, we are in the process of working towards trying to get a specific indication.
And what is, in your opinion, doctor, the prognosis for patients who undergo this IRE treatment?
So at this point in time, we do not have randomized controlled trials or studies which have been done in a prospective manner. Most of the literature that has been published from the United States on IRE in the pancreas has been retrospective. But what we've shown is that we've been able to provide a survival benefit to these patients of approximately 14 months from the date of the procedure. Clearly, this has to be validated in bigger studies and in trials, but clearly there has been a signal because the numbers seem to be consistent both from the surgical literature and in the percutaneous literature, and also in other centers around the world where this technique has been used and the data has been published. The numbers seem to be encouraging and providing a signal that there is indeed possibly a survival benefit here.
That's fantastic. What do you hope people take away from learning about this treatment, doctor?
The key takeaway message is that today there are other treatment options available. Traditionally, it was either just chemotherapy. If you're a surgical candidate, obviously that would be the best choice. But if not, patients just got chemotherapy or maybe chemotherapy and radiation. And most of the times, interventional radiologists and oncologists were just involved in palliative procedures. But now there is a treatment option that we can also provide where we can help patients. So there is one additional option, which in this particular space is huge.
Great stuff. Thank you, Doctor, very much. Thank you for sharing that with us. Coming up next, we're going to be talking about the importance of clinical trials when treating pancreatic cancer, including a current clinical trial that looks pretty promising for pancreatic cancer patients. We're going to have our entire panel joining me again, so stay tuned for that. You're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for our experts, please call us using the toll-free number 855-796-4475. Please be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel and watch videos from previous episodes. We'll be right back.
C stands for courage, collaboration, compassion, and cutting edge. With the most advanced radiation treatments, including proton therapy. At Miami Cancer Institute, C also stands for cure. World-class cancer care right here at home. Learn more at miamicancerinstitute.com.
Cancer doesn't run in my family. That really was the farthest thing from my mind. I've been an athlete my whole life, and I work in sports, so my mindset was just, let's fight. So our stories are all unique, so whatever you're going through, ask questions, get information, and be involved. Don't ignore the signs. Join the fight. I'm Tony Beasley, and I'm a stage 2 colorectal cancer survivor.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us once again is Dr. Horacio Asbun, Chief of Hepatobiliary and Pancreatic Surgery at Miami Cancer Institute, Dr. Raj Narayanan, Chief of Interventional Oncology at Miami Cancer Institute, and Dr. Ripal Gandhi, Interventional Radiologist and Interventional Oncologist, also with Miami Cancer Institute and Miami Cardiac and Vascular Institute. If you have a question for one of these experts, please call us using the toll-free number 855-796-4475. Dr. Gandhi, let me start with you. Why is treatment improvement urgently needed when it comes to pancreatic cancer?
Yeah, I think that's a great question. You know, as you stated earlier, the 5-year overall survival for patients with pancreatic cancer is, unfortunately very poor, less than 10%.
Right.
There's about 55,000 patients who are diagnosed with pancreatic cancer each year. About 45,000 patients die from pancreatic cancer alone in the United States each year. So we really got to do better. And I think there's a lot of promising technologies that we've discussed today. And there are other clinical trials and newer technologies which are really on the horizon right now.
Now that you mentioned clinical trials, I was reading here, there's one called Tiger Pack. Can someone chime in on what that is and what it's doing?
Yeah, so this is a clinical trial that we are involved in here at the Miami Cancer Institute and at the Miami Cardiac and Vascular Institute. And basically, this is a clinical trial in which we utilize a small catheter, which is actually placed in the arteries, actually feeding the pancreas. And through this catheter, we actually administer chemotherapy directly to the pancreatic tumor. And I actually have a video that I can show you
Let's do that right now,
demonstrates
yes.
How this works.
Let's roll that video and we can explain what the treatment is so our viewers can understand it a little bit more. Go ahead, Dr. Gandhi.
Very good. So this catheter is called a Renovo catheter here, and you can see this catheter here. And this little animation, this video is going to demonstrate how this works. So this catheter consists of 2 balloons, as you can see here, and this is actually placed into the arteries directly feeding the pancreatic cancer. So typically we'll go through a small artery in the groin, and this catheter is advanced here. I'm going to pause this right here just to show you that this here is the pancreatic cancer, and this is the catheter here. And the goal here is we're going to inflate these 2 balloons, and we want to go ahead and administer chemotherapy directly between these 2 balloons directly to the pancreatic cancer. So the 2 goals here are, 1, to isolate the chemotherapy directly to the pancreatic cancer, and 2, hopefully to decrease the side effects from the chemotherapy to the rest of the body as the chemotherapy is directed directly to the pancreatic cancer and not to the entire body.
Wow, and this is a clinical trial currently going on right now. How promising is this?
Okay, in the early data on this device and utilization of this technology, there were some very promising results. So what we're doing here is a phase 3 clinical trial, and basically what that means is that is really the standard of care when we're looking at cancer clinical trials, where we're comparing the standard of care, which is systemic chemotherapy, to this therapy, which is intra-arterial delivery of this chemotherapy, and patients are randomized either to standard therapy or this arm in multiple centers across the United States, and the overall goal is to see if this improves overall survival.
Wow, how long is this procedure, and are there any side effects to it, doctor?
Sure, the actual procedure takes about 1.5 to 2 hours, I would say. And this is done over a course of 4 months, every 2 weeks. So either patients are given regular chemotherapy or they're given intra-arterial chemotherapy through this balloon catheter. In terms of side effects, you have all this, similar side effects to chemotherapy, although I think these may be minimized given that it's localized directly to the pancreatic cancer. And then there are, some risks of just going into the artery, bleeding being the major complication, but that's extremely rare.
I don't know if we can take that video again. It's stopped right now on an area that it says therapeutic agent infusing target site. Doctor, can you tell me what that therapeutic agent means?
Sure. So specifically for pancreatic cancer, in this study, we utilize a chemotherapy called gemcitabine. So gemcitabine is the therapeutic agent, which is delivered directly to the artery and directly to the pancreatic cancer through this catheter. And so, we are one of, the few sites in the United States that actually has access to this clinical trial, and really hope that this is very promising. And one of the really state-of-the-art things in cancer therapy in general these days is targeted delivery of chemotherapy, immunotherapy, and other agents, and this is the goal in this study, to target the chemotherapy directly to the pancreatic cancer.
My goodness, when this trial is over, I really hope you come back and you give us more of the promising results that we're hoping come out of this. This is fantastic stuff. We have a chart showing the survival outcomes of different treatments. Dr. Gandhi, can you walk us through this and tell us exactly what we're looking at?
Sure. So this is really looking at, this is the 2-year survival in patients with, this is really locally advanced pancreatic cancer. And you can see with standard chemotherapy or chemotherapy and radiation, that is the red line and the blue line. You can see it's about 20 or 21% survival. In the early studies which were done with this catheter, you can see that the survival at 2 years is about 73%. Now again, this was in the early studies, and this really needs to be replicated in a phase 3 clinical trial, and that's what we're doing right now.
And I noticed with the green radiation and then red, can you tell us what that is?
Yeah, so again, the blue and the red lines on that graph are just, one of them was with chemotherapy and one's with chemotherapy and radiation. You can see that a very similar survival at 2 years. But when we're utilizing this catheter, and again, this is what I didn't mention, these are patients who have locally advanced pancreatic cancer.
Okay.
So the standard of care for something that is resectable or surgically removable, as Dr. Asbun discussed, is actually removing it. That is the best chance for overall survival, and that is our goal. But we're hoping with this therapy, we can slow down the advanced pancreatic cancer, improve survival, and if we're really lucky, we could actually downstage these patients such that the patient can have surgery eventually.
Thank you for sharing all that with us, Dr. Gandhi. Great stuff.
Thank you.
As we wrap up today's show, I want to leave our viewers with some hope and positivity, considering that tomorrow is Thanksgiving and we have so much to be hopeful for. A few weeks ago, we had a very special patient on the Health Channel. His name is Gary, and he has some great advice for newly diagnosed patients. Let's take a look at Gary.
You know, I went in for my 6-month checkup at the Miami Cancer Center, and I'm waiting for my car to be brought up by the valet. And I saw a lady there in a wheelchair with her family around her, and she was really down. And I said to one of the people around her, I said, "What's going on?" She said, "Mom was diagnosed with pancreatic cancer." I said, "Do you mind if I talk to her?" And they said, "No." So I kneeled down and I said, "Man, you're going to get through this. I had pancreatic surgery surgery for pancreatic cancer over 5 years ago. You have to be positive. You have a loving family. Just remember it. They all want you here. You want to be here. Think positive. Do what they say. Follow their instructions."
How inspirational was that? Having someone who knows, talk to someone who's going to go through it. Dr. Gandhi, that really makes a difference when someone is so frightened at that moment. Has someone just lean over and say, "I know."
Absolutely. You know, personally, my uncle passed away from pancreatic cancer. So, this cancer is very dear to me. But to see something like this, to see a patient who's gone through this have, excellent results, and to be able to relate to other patients, that speaks a lot.
November is Pancreatic Awareness Month. That's why we're doing this very special show, and it has been very special. Again, I say we have to be thankful. Tomorrow's Thanksgiving. I am thankful to all three of you. We appreciate all you've done. We appreciate that you're part of the Baptist family and doing everything you can to improve survival rates. Dr. Asbun, any last-minute words of hope that you'd like to give patients who maybe know an uncle or an aunt or a loved one?
Well, it's just exactly what you said. If you hear pancreatic cancer or pancreatic tumor, it's quite bleak. However, maybe I am biased, but you need to understand we wouldn't dedicate our lives to this type of patients if there will be no hope. And definitely there is hope. And I have seen many patients that have been cured with surgery and the other modalities. Then you never should lose hope.
Absolutely.
And I want to take the opportunity, since it's Thanksgiving, to thank my patients, because the courage that they have to fight, it's incredible. And we are very lucky that we work as a team with them. Then the problem is no longer theirs, it's ours, and we try to solve it.
Thank you for that, Dr. Narayanan. Dr. Narayanan?
I'm very excited about the technology that we talked about, having used it for nearly 9 years in different areas for cancer care. The FDA has given a breakthrough designation for irreversible electroporation in pancreatic cancer. This is very exciting news. The fact that the FDA has recognized that this technology has a potential in pancreas is encouraging. And the next step would be a trial, a randomized controlled trial, which we're hoping to roll out pretty soon. So I'm looking forward to that, and hopefully that would also help in the management of pancreatic cancer.
Dr. Gandhi, I'm going to end with you.
I think, I just want to stress what Dr. Asbun said. I think there is a lot of potential to really improve the overall survival in patients with pancreatic cancer. And really with the multidisciplinary approach that we have here at Baptist Health, where we have all physicians together, we can offer patients either surgery, some of these newer, really promising technologies, including IRE, and I think most importantly, clinical trials. I think if we really want to advance the care of patients with pancreatic cancer, these clinical trials are really the key, and I'm very hopeful.
And we can never lose hope. On that note, happy Thanksgiving to all three of you. God bless you all. Thank you so much, Dr. Asbun, Dr. Narayanan. It's been such an honor having all of you.
Thank you.
Pleasure. Thank you.
Please come back again. All right. And thank you so much for joining us today on the Health Channel. Please be sure to join us next time. Remember, it's All Health all the time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. You can also visit our website all the time. It's allhealthtv.com, 24 hours a day, 365 days a year. It's here for you. You can watch a live stream of the Health Channel. You can watch videos from previous episodes. We hope you have a wonderful Thanksgiving. As my mom says, Feliz Día de Acción de Gracias. I'm Olga Villaverde. God bless you all. We'll see you next time.